We're a small not-for-profit organization. We're based in Connecticut, but the reality is we don't really have a formal office. We all work out of our homes distributed across the country. And this little band of 15 people has been working diligently for the past 10 plus years to create, develop, implement, test various incentive programs from regular pay for performance all the way through bundle payments and beyond, patient-centered medical homes. We're working on various models on total cost of care, and we're also now starting to focus a lot on benefits, benefit designs, and how to create incentives for plan members that are going to match up with the incentives that are created on value-based payment. Well, if you look at this chart, what it represents is a relatively classic distribution of plan members in a commercial plan population. And so each one of the bars represents the total number of people who are within that particular category of spend, and the x-axis represents the average amount spent by that population, by that cohort, during the course of the year. And I've cut off the tail of the distribution because, as you know, there are a very small handful of individuals in any plan membership that spend far more than a couple of $100,000 a year. But it gives you a sense of, again, the distribution of costs within a population. So if you think about the two edges of the tail, the distribution of that distribution, today we really have two zones that we think of for those tails. One is a retail zone, and the other one is what we think about as the insurance zone. The retail zone is now the growing zone that is truly a retail market. So if you look at the average annual deductible for most health plans in the country, it far exceeds a couple of $1,000s. And that's the amount of money on average that the cohort on the left-hand side of the chart spends. So if the majority of the amount of money that you spend during the course of the year is less than $2,500, chances are you're spending all of it out of pocket. And that has driven already to date a fair amount of changes in the way the delivery system is organized, the emergence of retail clinics, the mergers and acquisitions between CVS, Walgreens, and others around those types of medical distribution. That's because it is a retail market. And in a retail market, it's not about you going to the provider's office. It's about the provider treating you as a customer because you're paying out of your own pocket. And what you want is convenience, expediency, and good quality, and as low a price as you possibly can get. At the other end of the spectrum is the insurance zone. Why? Because the sample sizes are small. The heterogeneity of the population is relatively large. Predicting the spend is a fool's exercise because it changes all the time. The mix of the patient changes. The nature of the diseases that they have changes. The pathways that they follow are most often catered to the individual and can't be generalized in any formal way. It's therefore incredibly difficult to manage patients under a budget in that zone because of the heterogeneity and the complexity of the cases. So what we're left with is this manageable zone. Chronic illness, routine procedures, large amounts of spend that collectively represent about 2/3, roughly, of what a commercial payer might spend during the course of a year. And the reason we call this the manageable zone is because that's the zone within which we know physicians who take a different approach at managing patients and who are paid differently than in the fee-for-service world actually are able to compress quite significantly the cost of care and improve the quality as well. So that's the zone that when we think about bundle payment actually fits very well with a construct like bundles because it's discrete, you can understand it, it's within the locus of control of providers, and they have and have been proven to have the ability to manage the spend in that area. So when we think about and talk about bundles, at least in our organization, it is very much in that manageable zone. It's not just the small, discrete, individual procedures like hips and knees, it's chronic conditions, it's cancer care. And if you look at the movement from states, and you'll talk more about this afternoon, from CMS, and they'll talk more about this both this afternoon and tomorrow, you can see that the trend is in fact going to this manageable zone. Why? Because that's where the money is. When we look at the distribution of costs for any episode, and that goes from chronic conditions, cancer, to discrete procedures like cataract, the distribution looks almost always like the one on this particular chart. And almost always the distribution looks like this, where the higher cost cases are on the right-hand side of the distribution, and they also are the cases that contain almost all of the avoidable complications. So the point is, that's the manageable zone. Progress is absolutely hampered by decades-old infrastructure. Most of the health plans in the country, and most especially Medicare's administrative contractors, have claims adjudication systems that were invented in the 1970s. So this is an issue that we absolutely need to collectively face into. Many plans have started to go down that pathway of not just facing into it, but also looking at implementing solutions, and you'll hear a little bit more about that during the 11 to noon session. If you're in the payer space, bundle payments means changing contracting mentality. And I think you'll hear from the Track 3 folks this afternoon that that's actually an incredibly positive change, because the dialogue between the payers and the providers changed from an adversarial relationship based on discounted fee-for-service to much more of a collaborative discussion around how you can create contracting modules that help both the payer and the provider have some gains. On the flip side, and as a mechanism to overcome that inertia, there is very significant latent demand by employers and providers to engage in direct contracting around these bundles. We're in discussions with a number of provider organizations across the country that are asking us to help them think through how they can go about doing direct contracting with employers. Now, why are they asking us? Back to point number one. Because when they go and ask many of their payers, the answer is, we don't know how to do this, it's too complicated, our systems can't handle it. Program design matters tremendously. What I mean by program design is when you're designing a program, whether it's bundle payment, PCMH, ACO, the decisions you make along the way have very significant implications on the desired effect or the actual effect of that program. Many of the design decisions that were made early on in BPCI were done for reasons of expediency. I think many of us in this room have since then highlighted the deficiencies that are created by that expediency and urged CMS to correct it, and that hasn't necessarily always been met with a forthcoming willingness to change. And so we need to learn from that, because if you design a program that eventually fails to engage the majority of the providers that you're trying to engage, you're going to have a problem. It's not going to be sustainable. And then people look around and say, this can't work. And the answer is, yes, it can if it's designed well. And finally, we know that clinical reengineering is very difficult, but there have been phenomenal strides by those who have engaged in the combined and joint effort between themselves as an organization, the payer, the right types of incentives, and the right type of clinical reengineering. And we have an entire track this afternoon that will deal with that, with actual examples of how that reengineering can occur, what it means to patients, what it means in terms of reducing the variability that I showed in that cataract example. So here's the role that we're trying to play in advancing the movement around this mode of payment reform and benefit design reform. We have finally come out with what I think, and not just I, but I think most of the people who use our analytics feel very strongly, is a state-of-the-art set of analytics that can create insights around the variability in costs of care, the effectiveness of various payment modalities, help power bundle payments and other payment programs, and that we're now finally in a position to formally release and announce. Many charitable foundations along the way have helped us develop what is now a really comprehensive library of episode definitions that can be used for various purposes. And we've published those as open source on our website with the entire file of all of the code sets associated to it. We'll maintain that. There will be an ICD-10 version that will come out later this year, and we're going to continue to maintain that for as long as we can, partially because there is no open source standard that exists around episode definitions. We're also going to be deploying in the next 60 days a free cloud service that we call Discover Your Opportunity, and that enables anyone with a claims data set to get a relatively parsimonious but hopefully insightful set of reports that helps them focus on what is it exactly within that distribution that I showed earlier that you should be focusing on. So instead of everyone focusing on the same old, let's do orthopedic surgery, let's do cardiac surgery, there's a lot of other things in that manageable zone, and we want to help people discover their opportunity within that manageable zone, and we do that as a free offering.